the importance of clinical trials with Craig Cole. I chose this topic so we could hear from not only a myeloma specialist, but someone who has direct knowledge of how clinical trials work in myeloma. Often clinical trials are not talked about in the African American community, or it's often associated with this negative connotation from past distrust that we are all familiar with. Dr. Cole understands the importance of diversity in clinical trials, and is also able to dispel any myths associated with clinical trials. When we gain knowledge, we're able to better make informed decisions when it comes to clinical trials. So Dr. Cole is going to give us some information today that's going to help us be able to make those more informed decisions. Dr. Cole is a board-certified hematologist who completed his undergraduate degree at Michigan State University and his doctoral degree at the Ohio State University College of Medicine. He began his postdoctoral training in internal medicine and hematology oncology at the University of Michigan Health System. He's had the opportunity to do post-fellowship laboratory research in the Jerome Leiper Multiple Myeloma Center of Medicine at Dana-Farber Cancer Institute, Harvard Medical School in Boston, Massachusetts. This opportunity then led to a staff lectureship at the University of Michigan, concentrating primarily on clinical research in multiple myeloma. Dr. Cole then became an attending hematologist at Gundersen Health System in La Crosse, Wisconsin for 9 years. While in Wisconsin, he expanded his research interests to include multiple myeloma, non-Hodgkin's lymphoma, therapeutic apheresis, and myelodysplasia, participating as the on-site primary investigator for over 21 clinical trials. He then returned to the Michigan State University in East Lansing as an assistant professor in the Division of Hematology Oncology with his primary clinical and research interests in multiple myeloma. He has published and presented his research at the American Society of Hematology and the American Society of Apheresis national meetings. He also has a commitment to patient empowerment and education, working with several local and national patient advocacy associations. So Dr. Cole, welcome. It's always good to have you back with us. The floor is yours.
Thanks, Valerie, and definitely thanks to Myeloma Crowd for inviting me back to talk about something that is very near and dear to my heart, and definitely been a large focus of what the myeloma community has been working on, is really understanding the differences in the biology of myeloma between ethnicities, and really looking for that cure. So I am going to share my screen and start my talk. And so again, today we're going to talk about the importance of clinical trials for the African American community, excuse me, with multiple myeloma. And the talking points for today is we're going to talk about the differences in myeloma between the ethnicities. So the important point there is to show you that there are significant differences in myeloma biology and in patients with myeloma based on their ethnicity. And the reason, and we're going to go through lots of points that show that there are differences. And the reason is that that if Caucasians and African Americans were identical with myeloma, then having diversity in clinical trials would not be important if everyone were completely identical. The fact of the matter is that patients with myeloma are very different based on their ethnicity, and therefore it is critical. And in fact, the American Academy of Cancer Research and the FDA really really saw the critical need to have improve the enrollment of people of ethnicity in clinical trials, because with this disease, everyone's not equal. And we need appropriate representation to make sure that, again, that we can find that cure for multiple myeloma for everyone. We're also going to talk about dispelling some of the myths about clinical trials, what actually are clinical trials, kind of the mechanism and thought behind it. And then we'll hit some conclusions and answer some questions. And so again, awareness of the differences and the awareness of some of the disparities and the need is the beginning of positive change. And hopefully I can deliver some of the solutions to that. So again, race and ethnicity and myeloma, that I think we've talked about before, about how the incidence of myeloma is higher than men than in women, and that overall about 20% of the myeloma population is African American in the United States, but that Blacks and people of African descent have twice the incidence of myeloma than Caucasians, and this is mirrored in the precursor condition MGUS. And this is not just in the United States, but around the world, that people of African descent have a higher risk and higher incidence of myeloma than other ethnicities around the world. That in 2009, the SEER database demonstrated that Blacks have United States, the incidence is 11 per 100,000 as compared to all races, Hispanics and whites, which were about 5 per 100,000, Native American 4.5 per 100,000, and Asians having the lowest incidence of myeloma at 3 per 100,000. And why is that difference exist is unknown, but we'll talk about some of that in a bit. And Blacks and people of African descent across the planet have the highest risk of myeloma than any ethnicity. And if you look at the incidence in race, and if you include age in that, you'll see that African Americans with myeloma have, as they get older, have a steeper rise in the incidence as compared to other ethnicities. So a person of African descent who is 80 doesn't have an incidence of 12 per 100,000, but is more like 75 per 100,000, markedly higher than the other ethnic groups based on age. A more updated SEER database showing that the incidence has been climbing for all ethnicities, but in blue, African Americans higher. And if you look at mortality, that the mortality is higher among Blacks compared to all other ethnicities, primarily because of the increased numbers. That there have been several studies that have shown that if treated equally, that Blacks have equal, if not superior outcomes compared to whites. However, based on pure numbers, the Blacks have a higher mortality. And you can see that those numbers have been going down over the past the mortality has been decreasing over the past 15 years. So there are significant differences in myeloma biology and risk. And just as a level set, I think everybody here knows that MGUS, all myelomas begin with MGUS, where patients have lower M proteins and no high-risk features, no symptoms related to that. And only a minority of those patients will then move on to smoldering myeloma and multiple myeloma, with the risk of turning into myeloma being only 1% per year for MGUS. And MGUS is incredibly common, and we'll talk about that in a second. Smoldering myeloma is when there's more plasma cells, the M protein is higher, and the number of plasma cells in the bone marrow is higher, about 10 to 60%. But again, patients with smoldering myeloma don't have symptoms of myeloma, none of the CRAB criteria that we've frequently talked about. But their risk of turning into myeloma is a bit higher at 10%. And then true and true multiple myeloma is when a patient has more than 10% plasma cells in their marrow and has a myeloma defining event as high calcium R stands for the CRAB acronym being C for high calcium, R for renal or low kidney function, A being anemia, hemoglobin less than 10, or B being lytic bone disease seen by CT scan, PET scan, or skeletal survey. In 2014, we expanded the treatment paradigm to include asymptomatic patients whose risk of developing those symptoms is greater than 85%. And those are patients that have bone marrow plastocytosis greater than 60%, or free serum light chains greater than 100, or more than one lytic lesion seen on a sensitive scan, such as an MRI, in those patients we treat. And we'll talk about the MGUS, smoldering, and particularly myeloma as the differences based on ethnicity. There are several events that happen along the way as a patient develops MGUS, followed by smoldering myeloma, and then end-stage myeloma. And there are lots of clonal drivers that change the mutation burden of MGUS to have it go to smoldering and multiple myeloma. But also there are extramedullary, extramural factors, such as obesity exposures. And really that is one area that we need to get a better understanding of some of those extra risk factors besides clonal competition and clonal evolution that drives MGUS into multiple myeloma. So the difference in incidence between the races can't be explained by tobacco, alcohol use, or socioeconomic status. Obesity, however, has emerged as a consistent, well-established risk factor for myeloma and outcomes in myeloma, and has been associated with increased prevalence of the precursor disease MGUS. And we do know from the NANES study that Blacks have a higher risk of having obesity than other ethnicities. And in our lab, we're actually actively investigating exactly how does obesity promote the transformation of MGUS into multiple myeloma. That has been, we've been thankful to have funding from the Department of Medicine and the Cure Myeloma Corporation in Michigan. Exposure to ionizing radiation is the most convincing risk factor for myeloma, but that really isn't anything that's particularly racially based. And chemical exposures over a long period of time, diesel exhaust, pesticides, nickel, and wood have been causative, but again, there isn't any particular ethnicity that's exposed to those chemicals in particular. Studies have demonstrated that and this is something that's been fairly new over the past 10 years, studies have demonstrated that having a family history of myeloma or MGUS is a strong risk factor for other family members to have MGUS and myeloma. And the excess risk of myeloma attributed to positive family history appears to be greater than Blacks and in whites. And when population studies and genomic studies have looked into it, that connection between family history and myeloma is stronger for Blacks than in whites, including a meta-analysis that was a genome-wide study, which suggests that there are myeloma risk loci genetically in Blacks that are distinctly different than risk loci found in European Americans. But we need more patients involved in those studies to understand these differences. Myeloma is, again, always preceded by MGUS and smoldering myeloma. And really that higher incidence that we see in multiple myeloma of 12 or greater per 100,000 is really related to a higher incidence of the monoclonal gammopathy of uncertain significance, the precursor disease. The higher incidence is also seen again in MGUS. But when they looked at transformation from MGUS to myeloma, it appears to be the same among the ethnicities. So although MGUS is more common in Blacks than in whites, the transformation from MGUS to myeloma is no different between the ethnicities. In a study, again, in the NANE study, which is a large population-based study that looked at over 13,000 patients, they found the incidence of MGUS in all the participants in the study to be about 2.4%. However, when looking at the ethnicities, that Blacks had a higher incidence of MGUS compared to whites at 3.7% as compared to 2.3%. And actually, the occurrence of MGUS happens sooner in Blacks than in other Caucasians. And basically, for plasma cell dyscrasias, both MGUS and myeloma, the Blacks have the occurrence of this disease about 4 to 5 to up to 10 years sooner than other ethnicities. This population-wide study, however, was unable to connect that risk of MGUS to tobacco use, education, socioeconomic status, autoimmune disease, chemical exposures, and there was a hint that obesity may have played a slight role, but wasn't completely causative. The presentation of myeloma is different, again, between the ethnicities, that African Americans usually present with myeloma, again, 4 to 10 years younger than whites. Pooled data from several clinical trials show that African American patients were more likely to be anemic than other ethnic groups, and also had higher LDHs, or lactate dehydrogenase. That's the chemical that's released when patients have lots of myeloma, or if the myeloma is dividing quickly, releases LDH into the blood. And a study that, through, again, the SEER database, found, and I think this is quite important, that Blacks had higher incidences of the myeloma-defining events, the CRAB criteria, the hypercalcemia, renal insufficiency, and anemia, as we just mentioned, except for bone fractures. And bone fractures and bony disease was more common in Caucasians, but the other myeloma-defining events higher in Blacks and in other ethnicities. One other point I should mention is that Blacks are more likely to have light chain myeloma than other ethnicities. And looking at genomic testing and looking at what mutations actually cause this disease, the myeloma cell, being cancerous, has corrupted DNA, and there's several ways to look at exactly what mutations cause the myeloma. One is by conventional cytogenetics, and the main way that we look at mutational testing in myeloma is using FISH, or fluorescent in situ hybridization. Gives us an idea of what mutations occurred that causes disease, and actually what mutations occur that are causative to risk, and how difficult it is to treat the disease. So myeloma is highly dependent on chromosomal abnormalities and secondary events, and we define myeloma as being standard risk or high risk. High risk being those mutations such as the 414, the 1416, 1420, and deletion 17 mutations, also the gain of chromosome 1 and amplification, more than one copy of chromosome 1, are now considered high risk, more difficult to treat myeloma as compared to standard risk, which includes the 1114 translocation, triples of chromosomes, and the 614 translocation. So when looking at the differences between the ethnicities based on these genetic alterations, a VA study that evaluates 17p deletions, the highest risk of those high-risk groups in myeloma, found that actually African Americans had a significantly lower incidence of having deletion 17p than European Americans. However, there was no differences in survival between the ethnicities when they've had those high-risk cytogenetics. Another study looking at almost 300 Black patients with newly diagnosed myeloma found that African Americans had significantly lower incidences of the 414 translocation, the monosomy 13, which is kind of an older high risk feature in myeloma, and monosomy 7, again, one of the higher risk categories for myeloma. And data from Emory University recently found that Black patients had lower rates of the, again, high-risk features of amplification of chromosome 1 and deletion 17 than white patients. However, in a study that had over 800 patients looking at cytogenetics, and this actually is very interesting because This study used a geographic population structure tool, a biogeographical ancestry assessment. So rather than asking patients, are you Black or white, they actually look at the genes to determine where the patients are descended from, if they're from African descent or European descent. This study found that the 1114, 414, and 1420 translocations, and in particular the 1114 translocation, were significantly higher in individuals with the highest African ancestry as compared to those with the lowest African ancestry. And the majority of those three cytogenetic groups were 1114. And therefore, the more close analysis to see what is the impact of 1114 based on ethnicity, and found that 1114 translocated patients were younger, had lower performance status, had more advanced disease. And a multivariate analysis, however, that there was no difference in survival. However, and again, as several studies have shown, that overall survival was better for African Americans with 1114 as compared to whites. And again, there have been other studies done through the VA where, all things being equal, that patients of African descent have the same, if not higher, overall survival compared to other ethnicities. So I hope that gave kind of an idea that there are significant differences in the ethnicity, between the ethnicities in the biology presentation of multiple myeloma and some of the outcomes. Therefore, now let's take a look at disparities in clinical trials. And this is for actually all from the NCI, that they have stated that clinical research is a critical resource for developing new drugs for prevention and diagnosis of a number of diseases, including cancer. However, the ability to trust and apply these results for clinical trial really are dependent on the type and number of patients enrolled in that trial. What I always tell our trainees is that when you look at a clinical trial, you're sitting in front of a patient, you have to ask yourself, is this clinical trial, are the people in this clinical trial the same as the patient that's sitting in front of me? Because if they're not, if the patients in the clinical trial are not the same as the patient sitting in front of you, you do have to question if the results of the clinical trial will apply to that patient sitting in front of you. And if clinical trials don't include minorities and people of ethnicity, then there's a question of whether or not the results of the studies are relevant to everyone across the board. One important point is that the FDA does not have regulatory or statutory authority to require the sponsored clinical trials to include demographic subgroups as participants in clinical trials. Although recently there's been word that the FDA is reconsidering that. So they can enforce if a investigator includes a specific number of people of ethnicity in clinical trials. However, again, that's under review. The number of clinical trials for cancer that has gone for FDA approvals have increased significantly in box B, but in box C, you'll see that the vast majority of people involved in those clinical trials have been white, and lots of studies where race was reported. Only a minority were people of ethnicity, including Blacks, Hispanics, and Native Americans. And again, when you look at percentage of patients enrolled in FDA approval trials of drugs that we use every day to treat cancer, is primarily people of European descent as compared to African Americans, Asians, and Hispanics. When you look at, and again, these are slides from the FDA, when you look at demographic representation in NCI approved, Natural Cancer Institute approved trials, that you'll see that given proportional representation of a particular cancer, that Blacks, Hispanics, and other ethnicities kind of fall behind, and older patients compared to younger patients fall behind the proportional representation. So those patients aren't being represented in the clinical trials. And when you look at, again, drugs that have gone for approval for the FDA, that the vast majority of drugs are coming from outside the United States and clinical trials being conducted in the United States, the vast majority of those patients have been Caucasian, with only a minority being of any other ethnicity. And for Blacks and African Americans, you'll see that very thin pink line at the very bottom. Again, low representation for cancer trials. While a lot of the trials that have gone for FDA approval are being conducted outside the United States. And given that, and you think about that a lot of trials are done outside the United States for FDA approval, and you look at the representation of Black or African American, outside the United States, only 0.7% of patients are African American involved in those trials, as compared to 87% of whites. United States, that number is more like 5.4%. So again, for these drugs, up for FDA approval, very low numbers of people of ethnicity involved in those trials, and a lot of those trials are not reporting race at all these days. And so these drugs are being approved, and with only a small group actually reporting sub-analysis based on race. And so if you think about it, and we talked about the incidence of myeloma, and that approximately 20% of the patients in the United States, of the myeloma patients in the United States, are of African descent, and the mortality being a bit higher based on ethnicity. However, for FDA registration trials, only 5%. So the African Americans bear a lot of the burden of the incidence and mortality of the disease. However, the benefits of the clinical trials, only 5% are having those benefits. An analysis of 9 large clinical trials over 20 years that in the United States, and particularly in multiple myeloma, only 18% were non-white. The enrollment of minorities has actually decreased over the past several years, with non-Hispanic African Americans decreasing to only 13%. However, one critical point is that patient race or ethnicity did not have any effect on response rates, progression-free survival, overall survival. So people of ethnicity don't have any particular higher side effects, and they do as well, if not better, than other ethnicities in clinical trials. So, and again, looking specifically at myeloma, the FDA was becoming very aware that myeloma biology is different between the ethnicities, but the enrollment was low. And so they actually reviewed the FDA database of new drug applications between 2003 and 2017, and found that during that period, 23 trials were submitted for approval. 20 trials included information on race. 3 didn't include any information. However, the median number of a percentage of Blacks enrolled in those trials for myeloma for FDA approval was only 4.5%. And trials conducted in the United States had better enrollment of Blacks at 10%. Again, knowing that the number of African Americans that have myeloma is 20% of the total population. And these are those 20 trials, and you can see that they're differences, including some drugs that only had 0.5% African American enrollment in those clinical trials. To address these needs, I was very happy to be honored to be part of the FDA AACR workshop and seeing how can we eliminate some of these racial disparities in myeloma. And we made recommendations in a paper that was published in March of this year, looking for our colleagues in research to help eliminate some of those racial disparities. Some of the things that we talked about is broadening the eligibility criteria for our clinical trials, knowing that African American patients have more anemia, higher LDHs, that it was important to broaden the eligibility criteria, but also that clinical trial sponsors should have a specific prospective diversity plan to make sure we set concrete clinical trial enrollments based on the population of the area around where the clinical trial is being conducted, and that pre-specific analysis on endpoints be performed on racial subgroups. And so at Emory University, they are very aware of what the population of African-American patients are in that area, and they set their accrual goals for myeloma based on that number. We are doing the same thing at Michigan State. We know the number of myeloma of African-American myeloma patients here in Lansing, and we set our clinical trial goals based on that. And in fact, I'm the diversity officer here at Michigan State to assure that the clinical trials, the design and recruitment strategies, and that our investigators meet their accrual goals, because we don't want to leave anyone behind. And we are recommended that the FDA review the divisions and to assure that the study plans are in place and ask sponsors to monitor targets. And I'm really also happy to say that a lot of the pharmaceutical companies and sponsors of clinical trials have actually taken these recommendations to heart and have diversity officers and do have targets for diversity plans and enrollment. So now I want to talk about, and probably the most important part of a clinical trial, hands down, are the people involved in it, the people that benefit from it. So now I'd like to talk a bit about dispelling some of those myths about clinical trials, and really kind of getting into what exactly are clinical trials, because clinical trials definitely save lives. I have seen that, been involved in clinical trials for 15 years and have definitely seen the benefits of clinical trials. So what is a clinical trial? This is right from the NCI website. The clinical trials are research trials that involve people. And through clinical trials, we find new ways to improve treatments and the quality of life. So it's just not looking at, are these treatments effective, but are they effective for people? And researchers design clinical trials to test new ways to treat cancer, to find and diagnose cancer, to prevent cancer, to find risk factors for cancer. Why is the incidence so high in African Americans, so low in other ethnicities? That is what clinical trials are designed to do. Also to manage the symptoms of cancer, the side effects, and have a better understanding of what patients go through so we can improve what's their experience. Clinical trials are the final step in a long process that takes years to go through. Before any treatment is used to treat patients with clinical trials, researchers work for years to understand its effects, how these drugs work, and are they effective in the laboratory. And here at Michigan State, we have many studies that are going on that are preclinical before they see patients. A minority of those will actually rise to the level of being safe and being effective. Once we have found that a drug is safe and effective in that initial development in the lab, then the drug is studied formally in animals, first studied in mice or in rats, and then moving up to larger animals to assure its safety, understand that these drugs actually work in living beings instead of in the lab. And if it passes that muster, then it has to go to the FDA. And so someone can't work on a drug in a lab and then start giving it to patients. It has to go through the FDA and through a rigorous process. And probably one of the longest processes is that initial development stage, going to animal studies, fixing the drug if it is not working or if it's unsafe in animals, because the FDA will definitely throw back anything that is not safe to move on to human clinical trials. And again, the vast minority of those drugs studied will actually meet the muster of FDA approval, and then the drug can be studied carefully in controlled clinical trials. So there aren't any guinea pigs in clinical trials. All the guinea pigs happen well before it ever reaches the FDA and ever comes near a human being to assured safety. By the time it gets to patients, it has been rigorously studied, understanding that it is safe for everybody. So once it has been approved for use in patients, then it goes through a phase 1 clinical trials. And here we get an idea of what exactly how does this drug perform in human beings. Sometimes they're given to healthy humans before they're given to patients with cancer. Sometimes if the drug is found to if the FDA says it is very safe in early preclinical studies, sometimes it goes directly to cancer patients. So phase 1 is really to understand the safety and side effects, as well as the dosage. And usually phase 1 studies will start at very low dosages and then slowly increase up with a very low number of patients involved in those clinical trials as we understand sort of the dynamics of a particular drug. Once it has gone through a phase 1 clinical trial and shows that it has some effectiveness and is safe, then it moves to phase 2 clinical trials. Phase 2 clinical trials includes many more people. And here we're really, after we understand some of the side effects, some of the changes that happen in the phase 1, understanding that, now the phase 2 is looking to see, well, how well does this work? And we're looking in larger number of patients to assure the drug safety. Once it's passed the muster of a phase 2 clinical trials, and it really shows that it has promise for being as a new effective therapy for myeloma or for cancer, then it goes to a phase 3 trial. And here it goes up against the current standard of care to see, is this new drug, is this new procedure, drug, scan, how does it compare to the current standard of care? Because if it's worse than what we're doing now, then we don't want to do it. If it's better than what we want to do now, that's what we want to move into. Once it is approved that it is better than what we're currently doing, then the drug receives FDA approval, so it's available to everybody and becomes a standard practice. And then even after drugs are FDA approved, the FDA continues to gather information in large populations to assure that the drug remains safe over long periods of time of observation. And so probably the most common question I get about clinical trials about randomization. That many clinical trials are randomized to have people and doctors understand and to compare new treatments compared to the standard of care. And patients are usually divided into 2 groups at random. So you have a bunch of patients, and then a computer randomly assigns those to either receive the best available treatment. And so the control group is not getting a placebo necessarily, or they're not receiving any placebo. They're receiving the best standard of care. Unless the standard of care is observation, and especially for cancer, during randomization, the control group will receive the best available treatment. And so patients always get good treatment. The treatment group usually will have the best available treatment plus a study drug to see, is it better than what we're currently doing now? So everyone who gets randomized, there shouldn't be a fear of randomization because you'll get the best care no matter what. You'll get the best care that's available, or you'll get the best care plus an extra drug to see if that extra process or extra drug will have benefit over the best available treatment, which makes everybody happy that everyone's getting good treatment, regardless of randomization. So each clinical trial has a written detailed written protocol that includes why the study is needed, the purpose of the trial, what drugs are being tested, and what's the follow-up schedule. The safety measures, all the side effects are listed in the written protocol, and how the outcomes, when we know that this has worked or if it hasn't worked, and who exactly is eligible for a clinical trial. And those are some of the changes that we need to make clinical trials more available for larger numbers of people. And most importantly, how the clinical trial will be organized. One site or multiple sites, how many patients are supposed to be on the trial, now how many people of ethnicity are involved in those trials. And if a clinical trial is multi-site, all the participating physicians and staff must follow the exact same protocol. So a protocol that is done through one of the cooperative groups, which most trials are being done these days, everyone is doing the exact same protocol. If someone doesn't follow the protocol, then there are deviations of protocol which can threaten to shut down the trial at any particular site. So everybody is extremely, extremely adherent to a protocol, more so than any other really part of cancer medicine, that we go strictly by the letter. So patients who are on clinical trials get a lot of attention and support. They have a research coordinator that follows every side effect, everything that happens. They have a clinical nurse that follows everything, and they have the investigator that follows what's happening. They also have the sponsor of the clinical trial, making sure that that safety is maintained for patients during clinical trials. Patients are watched closely by their doctor and other other members of the medical team, as well as the sponsor of the clinical trial from afar. So the sponsor always asks for outside experts to review the merit of a study. Many centers will have a protocol review committee that any clinical trial has to go through to make sure that the clinical trial is appropriate for that particular center, for that particular population, before it is ever approved. It makes sure that it's safe, is scientifically sound, and that it can be performed as appropriate for that population. And then the Institutional Review Board, which is a committee of experts. Some are medical, some are non-medical, some are patients. And they look to see, is this trial of scientific, legal, and ethical merit? Are the risks minimized, and are they reasonable? And they help weigh that risk versus benefits. Is informed consent process in place and is documented? And does data monitoring make sure patient safety and that we know that it's working? Is there a process to protect the privacy of patients? And probably the Institutional Review Board is probably the biggest safeguard and the strongest safeguard. And probably one of the most difficult parts of opening a clinical trial is getting it through the Institutional Review Board, because they look at every sentence and every word of a clinical trial to make sure that it's safe and that patients are well informed before they ever come near any medication involved in a clinical trial. So your doctor must give you an informed consent document before you can enroll in a trial. So the consent document has been approved by multiple review boards, including the Institutional Review Board, to make sure that patients clearly understand what's happening in the context of the clinical trial. It must be in a language that you understand, and ask for an interpreter, even though most clinical trials come in multiple languages these days. I always ask patients to bring an advocate, a family member, to kind of another set of ears to hear what is going to take place in a clinical trial and going over the consent form. But make sure you ask your doctor to explain everything you don't understand. Take your time in reading and signing a consent form for a clinical trial. I never, and in fact, really the standard is that patients never sign a consent form during a clinic visit, that they have to take it home. They need at least 24 hours to review the consent form before anyone can sign a consent form, because they need to review it, talk to their families about it. So I usually bring patients back twice, if not 3 times, going over the consent form, making sure that everyone understands the risks and benefits being involved in a clinical trial. Regarding healthcare coverage and the cost of clinical trials, it's really important to find out what will be covered. Some costs will be covered by the sponsor, and usually the drug costs are covered by the sponsor of the clinical trial with no cost to the patient. And really the bulk of the costs of the clinical trial is really in the drug that's being studied. The standard of care costs are usually covered by the health insurance, as they would for any other standard of care procedure. So if you're on a blood pressure medication during the clinical trial, the blood pressure medication will be covered by insurance, while the study drug will be covered by the sponsor. Some costs that may not be covered by your insurance would be, again, standard of care things. So if you're hospitalized for some reason, or if you have a doctor visit for an orthopedic procedure, separate from the clinical trial, of course, your regular insurance would cover those. Laboratory testing that is not part of the clinical trial will be covered by your standard insurance programs. And many clinical trials these days offer stipends and help to arrange for travel for patients during the clinical trial. So medical mistrust, and this has been, I think, in the past 15 years, this has been one of the biggest changes that I've seen in clinical trials. That medical risk mistrust is really defined as an absence of trust in healthcare providers and organizations. That people don't feel that these organizations truly care for the interest and are honest with patients. And it's just not related to the past legacies of mistreatment, but also stems from really contemporary experiences of discrimination of healthcare that are ongoing today. And it is, and more so now than I've ever seen, that there is awareness of really now all researchers of what has happened in the past and present abuses. And it's now required for all persons conducting clinical trials to be aware of those risks. So clinical trials are conducted by good clinical practice guidelines, and anyone that's involved in clinical trials has to have a good clinical practice certificate. That certificate includes, from the FDA, includes a section that has to go through the atrocities that have happened in the past. And so your doctor is aware of those things and is very cognizant of it. And you should be cognizant of it. But it isn't that people have thrown that away and no longer consider those. Those are current issues that we're going through. But I can assure you that there is more protection against abuse in clinical trials. And every clinical investigator has to do the good clinical practice guidelines in order to conduct clinical trials at all. So we've asked myeloma patients about their belief about clinical trials. This was done a few years ago, where the cancer support community did ask myeloma patients, so what do you think about clinical trials? And the top 3 concerns that patients had, beliefs they had about clinical trials, is that they were uncomfortable with being randomized. They had a fear of receiving a placebo and a fear of side effects, with also the fear of health care, their health insurance wouldn't cover it, and medical mistrust of being a guinea pig. And 35% of the registrants were unsure if a clinical trial was available to them. So factor myth, based on that information that we see that a lot of patients have about clinical trials. So factor myth, if I enter a clinical trial, it's a good chance that I would receive a placebo. And that's a myth, especially in myeloma, that placebos are rarely and really not used in cancer clinical trials anymore. If you have cancer, they can't randomize you to no therapy at all. That would be that would never get past the FDA or any institutional review board. Placebos are rarely used. Again, randomized clinical trials are best current care, the best care that is currently available, the standard of care, versus the treatment arm is the best available care plus the investigational agent. So there are no placebos that are given. Clinical trials are riskier than FDA-approved drugs, and that's also a myth. The treatment on clinical trials has a good chance of success because it has passed all of those safeguards to make sure that it is effective and safe for patients. And the drugs that are approved by the FDA all started at clinical trials, and they were found to be safe at that point. Clinical trials, the trial itself is more important than the patient, an absolute myth. And to me, I encourage patients to go in clinical trials because they are the most important part of the clinical trials, and that you can stop a clinical trial participation at any time for any reason without any repercussions at all. And so if you say, gosh, this clinical trial isn't for me, from the time you sign to the very end of the study, you can always opt out of the clinical trial with absolutely no repercussions. You are really the star of the clinical trial. If my doctor doesn't mention clinical trials, it must not be right for me. And that is also a myth. The fact of the matter is that your doctor may not be aware of the clinical trials that are available for you. And so it's really important, especially being on education forums like this, to be able to find the clinical trial, especially if you have multiple myeloma. Clinical trials are available only for people that have advanced cancer, and that is also a myth. Clinical trials for myeloma are now available for patients at every stage of disease. There are MGUS trials, there are pre-MGUS trials, there are 76 smoldering myeloma trials that are ongoing right now. There are multiple newly diagnosed trials for patients in maintenance, transplant trials. The wealth of clinical trials in myeloma is now vast and not just relegated to patients with advanced cancer. Clinical trial drugs cost too much money. That's a myth, because the actual drugs used in those clinical trials are covered by the trial sponsor, and all other costs are usually covered by the insurance, especially if they aren't directly related to the clinical trial. So there's no increase in cost accrued by being on a clinical trial. And the biggest one, if I enter a clinical trial, I'll be a guinea pig. And that's a myth. The clinical trials provide the best available therapy for a patient, and possibly an even better therapy for patients. And I guess I would say, one important thing that's specific about myeloma is that the myeloma space, you've heard so many good things and so many breakthroughs in myeloma. The myeloma space has become incredibly competitive. So only the best drugs actually make it to the clinical trials because there are so many good things happening in myeloma. 15, 20 years ago, when there were only 3 or 4 drugs for myeloma, we were trying lots of new things for myeloma. Now that we have a wealth of different therapies for myeloma, it has become very competitive. which is good for patients, because only the best clinical trials are actually getting to patients these days. And this is a representation of some of the clinical trials that are currently some of the new drugs are being investigated in myeloma, including phase 3 trials, including some of the new CAR T therapies, and the ones that are in phase 2 and phase 1 clinical trials, including the bispecific antibodies, a lot of small molecules that are involved, including, I would bring your attention to venetoclax, which is, there was just a fantastic publication that came out that was just published yesterday on venetoclax for 1114 myeloma, and how patients had incredible responses in venetoclax clinical trials when combined with daratumumab and Velcade. And again, I would have you remember that venetoclax works particularly well for patients with 1114, and African Americans have a higher incidence of 1114 than other ethnic groups. So how do you find clinical trials? Well, the HealthTree, when you go under clinical trials in HealthTree, it has you get started on finding a myeloma clinical trial that is close to you. And you can always go to the NCI and the National Cancer Institute. And when you go to the NCI website, this purple dot will follow you all over the website. It won't leave you alone until you click on it to find a clinical trial that will be appropriate for you. And you type in multiple myeloma, and again, you can see the vast wealth of the different clinical trials that are available in multiple myeloma. So how does myeloma care advance? So, we start out, in the 60s, we started out with therapies that had lots of bad side effects and had poor effectiveness. So urethane and melphalan pills were not very effective and had terrible side effects, but that was the standard of care. Clinical trials took place in the 60s, and those drugs were the standard of care. But as time has gone on, there have been more clinical trials that have then become the better standard of care. Revlimid and dexamethasone superseded melphalan and prednisone that then became the standard of care. Then Revlimid, Velcade, and dexamethasone, RVD or VRD, then superseded Revlimid Dex to become the standard of care. And now we're getting drugs that have very little in the way of side effects, and their efficacy is fantastic. And I can't wait to see how some of these new drugs are becoming a standard of care that are really changing the landscape and the livelihoods of patients with myeloma. And as patients climb up that staircase of clinical trials to standard of care, it is inevitable that we'll reach a cure for this disease. The key is to make sure that cure is equitable for all patients of different biologies and different ethnicities. So I hope that it's a bit clear that biology and representation of myeloma is different, of people of African descent, different than those with European descent, and that with equal delivery of care, the survival of patients with myeloma is equal, if not favorable, for people of African descent. The survival of people with ethnicity is similar to that of whites when enrolled in clinical trials, but we need appropriate representation in myeloma trials to ensure that these new drugs work equally for African Americans and really for all patients with myeloma. And for clinical trials, it's important to know this is an important option for everyone. It can be for newly diagnosed, limited disease, advanced disease. They're appropriate, safe for patients of all ages, genders, and races. And that we need to include people of ethnicity in knowing if these treatments work for everybody. So take into account all those factors, as well as the stage of disease, treatments used, in the presence of any other medical conditions to assure safety. And remember, communication with your healthcare team is critical in making all treatment decisions, but especially clinical trials. And so we are definitely reaching for equity in cancer medicine, that everyone can see us knock it out of the park and to cure multiple myeloma. Because without change of what we are not aware of, we can't change what we're not aware of. But now that we are aware of these differences and we hear the call to enroll more people with ethnicity in clinical trials, we can't help but change. And that's it. So thank you for your time and attention. That's our new hospital that we're opening, and that's where the labs that we have. So thank you. There's my email address.
Well, thank you, Dr. Cole. That was an awesome presentation. I mean, awesome. I got a page full of notes over here. And it's just the way you know, what you guys are doing to eliminate those disparities where you are. That is just amazing. And also dispelling all of those myths. I think you hit on every myth that has ever come up. And that is just, I appreciate that. We are gonna open up for just, we do have some time for Q&A. So if you do have a question, you can raise your hand. Should be a little button down at the bottom of your screen. You can raise your hand, or either you can type it in the Q&A box. And while we're waiting on questions, one thing that I thought of as you were talking, Dr. Cole, you mentioned that a person could get out of a clinical trial at any point. Does that mean that they could never get back in that trial or any other trials in the future? Does that eliminate them from that?
Yeah, that's a super good question. If you are on a particular clinical trial and you then decline being on the clinical trial, depends a bit on where you are in the course of the clinical trial. So if you're at the very beginning and have not received any study drug, and then you've had a patient who didn't enroll because they had to go to a family event. And so we told them that, gosh, you know, with you being gone for a month to go to this family event, that you can't be enrolled in the clinical trial. So they withdrew their enrollment. When they returned after the family event, then they went right back on the clinical trial. Usually, if you've already received the particular, you know, drug in question, then you usually can't re-enroll in the clinical trial, because then it's unsure of what happened when that person was off the clinical trial, and is the drug going to still have the same effectiveness if there's been breaks in it. And so been breaks in the therapy. And that's part of the stringency of the protocol. That the protocol is really the written information of how that trial can be conducted. And if there are any lapses or breaks or non-compliance with that protocol, then usually that part of the trial then ends. If you're off a clinical trial, can you go back on any clinical trial? Absolutely. We have lots of patients who go on one clinical trial, have a good experience, and go on another clinical trial for myeloma. We've had a patient that was on a newly diagnosed clinical trial that ended after they received their transplant. They went on a maintenance clinical trial after that. And then later down the line, years later, they relapsed, went on a relapse clinical trial. So really, you can go on a number of clinical trials. We have lots of patients who go from clinical trial to clinical trial in order to really reap the benefits of being on the trials.
Okay, and kind of like a piggyback on that, oftentimes patients are nervous about what will happen if the treatment they are placed on and that randomization side, if that doesn't work. Are they able to get out of the study and start a different treatment that's just not part of the study?
Yeah, that's, I'm going to say it's a super good question every time, because that's a super good question. So the very first safety thing that's included in the protocol is, if it's not working, you have to stop the trial. So even before, probably minutes before the patient knows, really as soon as the labs come back to say, has someone not responded, then the clinical trial ends pretty much automatically as part of the protocol. And so to assure that patients don't remain on the clinical trial that's not working for them. There are also hard stops for clinical trials based on safety. And I would say that's probably one of the toughest things, that if a patient is on a clinical trial and they get in a car accident of something unrelated to the clinical trial, and if they may need to come off the clinical trial because they're in a car accident, if they have a prolonged hospitalization and their disease recurs. And so, the protocol part of the clinical trial assures safety, that if someone is off therapy for a long time because of unexplained reasons, or if the treatment isn't working, then the trial automatically ends in order to maintain the safety of the patient.
Thank you. There's a question: where do you think the greatest success will be, novel agents or immunotherapies?
Gosh, that's like asking me to which twin. I got a set of twins. Which twin do I like more? And to that end, using my twin analogy, I think it's really both of those. I think my twins are funny and as individuals, but when they get together, I kind of fall off my seat. And I think that really right now we're in the process of doing clinical trials, seeing what novel agents, molecular therapies like venetoclax are doing. And we're also using the immune therapies. Just in that venetoclax DARA trial that was just published, the merge of those two appear to be very synergistic. And so I think my greatest excitement is when we bring the novel agents attacking the biology of the myeloma, and the immunotherapy agents getting the immune system to clear the myeloma. It's tough for the myeloma to survive when it feels sick and it has the immune system attacking it. So I would say that really it's the synergy between those two that I'm most excited about.
Okay. Is it wise to continue to seek clinical trials if disease continues to progress? Some patients chase trials seeking a cure. When do you stop?
That's a super good question. And I guess there are kind of two answers to that. You're right, and that there are so the wealth of the embarrassment of riches that has happened in myeloma, that there are new clinical trials that are coming out every day, and some people they see a brand new Honda, and then they see that brand new Ferrari, and then they see that brand new Lamborghini, and they're going from one trial to the next. And it really is, what I encourage my patients to do is really sit down and really read the clinical trial, do your research. And, in the same way that, you can make the same analogy for cars, that I just don't go to the dealership and just buy a car, that I do lots of research. I spend weeks researching something. So I'm going to sit in it for a while. So I spend weeks researching it, making sure that this is the exact fit for me, looking around at other clinical trials and other things that are going on to make sure because I can't afford a Lamborghini or Ferrari. So I can't afford that, but making sure is that Honda, is that Subaru really the best car for me? And that would keep someone from going from trial to trial. And that's why we slow everybody down. We say now that, that we have identified you for the clinical trial and you've identified us for the clinical trial, let's sit and really read this. And when I talk to my patients with clinical trials, I put other options. So I write down the clinical trial option versus another clinical trial option versus this standard of care versus that standard of care versus another newly diagnosed, newly approved treatment. And I say, which one is the best for you? Which one is the best fit for you. And we don't make any decisions there. Just like when you're buying a car or a refrigerator, we spend time researching it individually to make sure that's the best fit.
So thank you. The next question, do you know what therapies have the least negative side effects?
Well, that's what, we're trying to do two things. Of course, we're trying to limit the side effects of the clinical trial and of the trial drug, and to maximize the benefits. One thing that happens as we do a clinical trial in real time is we get an idea of of management of the side effects. So years ago, in fact, I just got off a phone call with talking about a particular drug that we did a clinical trial on about 5 years ago that had quite a few side effects. And in real time, as we were having patients on the clinical trial, we found solutions to those side effects. So the side effects that were there in the first few patients then were really eliminated because we understood how to dose and how to change the drugs during the clinical trial. And so really any clinical trial, especially by the time it's reached the muster of a phase 2 and phase 3, a lot of the side effects have been understood and figured out and treatable. And again, these days with how competitive clinical trials are in the myeloma space, we've really been very cognizant of minimizing clinical trials. So one quick example is neuropathy. We know that lots and lots of patients with myeloma receive Velcade as part of their induction therapy. Some of them have neuropathy. So really in myeloma, we have a zero tolerance policy for neuropathy. Patients have gone through that already. So you won't find very many, if any, clinical trials that will have neuropathy in 2021 because we have zero tolerance for that, because that happened in the past. We're not going to have it happen again. So as we move forward, we have less side effects.
Thank you. And this will be the last question. Is the CAR T clinical trial over? Will the sponsor pay for the care necessary after patient is discharged and live alone, especially considering the neurological side effects?
Yeah, that's a really good question. And some of that is dependent on what the exact protocol has built into it. And how long ago was the clinical trial written, and how much knowledge did we have about some of the neurologic and cognitive changes that happen with CAR T. And so it really is very dependent on some of the details that were in the consent form and in the clinical trial protocol.
Well, thank you so much for being with us today, Dr. Cole. We always enjoy you being here with us.
Thanks for inviting.
Yes, always welcome here. I encourage you to join us next month as we have the privilege of hearing from a renowned multiple myeloma specialist, Gareth Morgan. As one of the top myeloma specialists in the nation, he's made his mission to study genomics of myeloma in order to find the best treatments for this population and pave the way for a cure. Please come to this event. Invite all of those you know in the myeloma community to join you and hear from this very special guest. Now, we'll note that this session will be an hour earlier than normal. And also, we'd like to take a moment to announce a once-in-a-lifetime event that we have coming up here. We have the privilege to hear Dr. Jim Allison. Dr. Allison is an immunotherapy pioneer and Nobel Prize winner. His unconventional thinking led to the treatment that we know now as immunotherapy. You'll have the opportunity to watch his documentary for free and then come to ask him your questions on November the 15th at 3 p.m. You can sign up today on the Myeloma Crowd website. You can see the links and just click to sign up. You may be interested also in other Myeloma Crowd community events that are coming up. And just about an hour or so, we're going to have the Nutrition and Wellness Chapter event. We're going to be hearing from a dietitian that works at a cancer specialty center and how we can manage our side effects with nutrition when it's possible. On the 2nd at 1 p.m. Eastern, we're going to have a myeloma financial coach chapter. We're going to hear from Diana Valentine and John Borland about creative ways to find life insurance, even with cancer. November 3rd at 7 p.m. Eastern, the Muscles for Myeloma chapter is welcoming back myeloma patient Jeff Abram. He's a yogi who knows all about the uncomfortable side effects of myeloma and multiple myeloma treatment. With his knowledge and experience, he's come up with an excellent chair yoga routine that all yoga exercise levels can try. The link to sign up for any of those events and even more that I haven't mentioned here today is found at the bottom of the slide and will be sent out in a follow-up email to you within 48 hours of the event. And we'll also send you some information on where to find some of those clinical trials that you may be considering. I know Dr. Cole mentioned some, but we're going to give you some information as well in the email. So once again, thank you to our sponsors, Bristol Myers Squibb, Takeda Oncology, Carrier Farm Therapeutics, Adaptive Biotechnologies, Oncopeptides, Janssen Oncology, AbbVie, Sanofi, Amgen Oncology, Genentech. And thank you for helping us build the strong myeloma crowd community. I appreciate each of you and hope you have a great rest of your day. Bye-bye.